Familial hypercholesterolaemia is a condition caused by different mutations leading to increased LDL cholesterol in the circulation. Unfortunately, this condition is severely underdiagnosed and undertreated, probably due to the fact that you cannot feel the high cholesterol. You have to test it to find it. Per March 2018, there are 7,900 patients with a genetic FH diagnosis in Norway. And these are the three most common mutations in the LDL receptor gene. We have about 200 patients with a mutation in ApoB 3500Q, and we have less than 100 patients with a gain of function mutation in the PCSK9 gene. What we did in this study was simply to link those who had FH with all hospital discharge data on CVD in the period 1994 to December 31, 2009. We also performed a link to the cause of death register, and standardized incidence ratios were calculated by indirect standardization. FH patients without previous acute myocardial infarction or coronary heart disease were included only. So we had a 7-year washout period prior to the observation period. Standard incidence ratios were calculated by indirect standardizations, and the reference rates were the MI or coronary heart disease incidence rates for the total Norwegian population during 2001, 2009, stratified by sex, calendar year and 1 year age groups. Here you see the numbers in details with 111 women incident cases, and for men 142 incident cases. This column represents person years in 1,000. This is the crude incidence rate per 1,000. This is the expected number in the general population. And this is standardized incidence ratios calculated by dividing observed incident cases on the expected. And as you can see, you have a 17-fold increased risk in young women and 11-fold increase in young men. We see the same pattern for MI, for CABG, for coronary intervention procedures, and we believe this is linked to the fact that these patients had the FH mutation. We can put this in a more visual context, where you have the general population at the level of 1, and this is the excess risk found in FH. So in conclusion, even in the statin area, there is still a relative excess risk in FH, and this is highest in the youngest age. So carrying an FH mutation generates significant costs, both in economical terms for the society and in human terms for the individuals and their families. Clearly, action is needed to identify FH patients much earlier in life prior to disease.